Good morning to one and all. I'm Dr. Priyanka. Today's lecture topic is recent advances and materials in prosthodontics. So, coming to the learning outcomes. So, that means by the end of the lecture, you'll be able to summarize the recent advancements in prosthodontics, compare the difference between newer techniques with older ones, recognize the effects of using recent advancements. Okay, so coming to the introduction, as you all know that since dentistry has been started till now, there's been a lot of upgradation and changes which takes place daily in materials, in systems, in instrumentation. So the world of dentistry has been expanding worldwide, and because there is so much advancements in the scientific and the technological basis, the patient has higher demand and higher expectation, so that would increase the better quality of life for the patient. So obviously dentistry has come a long way from replacing a missing teeth to replacing a lost alveolus, supporting facial structures, or recreating aesthetics, or creating phonetics, or and in major and there are many other major developments happening. So we can say that prosthetics, by using all the artificial materials as well as technologies, we can give natural appearance to the individual, and we can improve the mastication, the phonetics, and the aesthetics. Okay, so coming to the recent advancements in terms of complete denture. So the basic advancements which took place was sorry, just okay. So it took place was in digital impressions. So we have started doing digital impressions for mostly everything now. So this has been introduced as in terms of a new intraoral scanner system. So by the intraoral scanner systems only, you can take a digital impression. So it allows the intraoral digital impression allows the clinician to directly acquire the data from the mouth without pouring a cast or making a conventional impression, and basically without limiting the error factors. So intraoral scanner has the ability to form an image directly by placing an scanner in the patient's mouth, and it can be very accurate, as accurate as in a conventional impression. So, steps needed to fabricate or reduce their potential errors, which are reduced, which are expansion, shrinkage, distortion. Okay. However, few studies have been published regarding the application of digital technology in records of an edentulous patient. So studies are still been going on. So edentulous jaw actually represents a mucosa-based clinical situation which involves several mobile zones, that is the oral vestibule, and smooth surface texture which is covered by saliva. So there are still attempts made to introduce the digitizing system for generating a digital edentulous model. So we can, do bite registration, we can take impressions, we can do scanning of the. Okay, so this is one example. You can see the upper, for the upper denture, the upper arch, we are fabricating a complete denture for the upper single denture. So this is a pre-op clinical view. So this is the view from the patient's mouth. This specific thing is known as a scan retractor. So this is used to put in the maxillary edentulous arch. So when you put it in the arch, you can see and scan the whole arch, and you can get a rough extent of the arch. You can get exactly an extent till you move the scanner around. So you can see this is the scan of the from the oral scanner. Okay, so now for a bite registration, how you can do is you can take a scan of the lower, and now you can put an interocclusal record material. So you can put a putty and a light body material and tell the patient to bite, and Now you can cut through the impression from the anterior portion, and you can get a record of the interocclusal placement, and you can see that the materials are still there and the patient is able to bite on top of that. So this is a bite scan image. Okay, coming to a virtual articulator setting. So this is all in the intraoral scanner. So you can place your models and rotate this in all the angulations. So this is like a fully adjustable articulator, semi-adjustable and fully adjustable articulators, and you can work on the condyle levels. You can increase or decrease the incisal guidance, and you can see it in all the, you can view it from all the angles. So this is the virtual models aligned. Okay, so once everything is done and you're ready to fabricate a milled denture, so here you can see there's a milled denture base plate with the teeth. Okay, so these can be put on top and cemented, and the placement can be done. There is the complete prosthesis. Okay, so these are the virtual articulators. There are a lot of settings which are present in the software. So the software comes with lots of settings which you can adjust, and you can choose which articulator you want, how do you want to place it, how much tilt, how much angulation you want to give. Everything can be viewed on the screen rather than in the patient's mouth or on the model physically. Okay, so coming to the recent advancements in the fixed partial denture, so CAD-CAM. CAD-CAM is a big thing now, and it has increased in the popularity for the past 25 years now. So what is CAD? That is a computer aided design. CAM is computer aided manufacturing. So CAD CAM works together. It is basically the designing and the manufacturing of the processes. So it can be applicable for veneers, crowns, inlay, onlay, FPD, implant abutment, even a full mouth construction can be done. Okay, it can also be used in orthodontics. Okay, coming to the three major challenges which can be faced. So one is to acquire the adequate strength of the restoration, especially the posterior teeth. The second is the creation of restoration with a natural appearance. And thirdly, to make tooth restoration easier, faster, and more accurate. Okay, so these are the challenges which are solved by the CAD-CAM. Okay, so we have used CAD-CAM for our benefits to help in all the three challenges. Okay, so a dentist can take a digital impression, send to the lab, and if there is a lab associated which does the CAD-CAM work, it can be sent to that lab, or a dentist can also own a CAD-CAM and a milling in-house machine, so he can have a lab with all the facilities, so it can be done. So when the labs receive the digital impression, they create a stone model from the data, and either continue to do the traditional fabrication or rescan the model for milling, and then they proceed further with the designing by the computer from what they have received. Okay, so overview of CAD-CAM. So CAD-CAM system consists of a handheld scanner, a cart, a monitor, and a milling machine basically. So what it does, if you place a scanner example for above the tooth preparation, and the resulting data appears on a 2D or a 3D image, design work is done on a monitor. Instructions can be sent to the computer assisted processing machine for milling. So everything can be done by the computer, and it can be milled in the milling machine. It does not have to involve anyone physically pouring the cast, or you having to give instructions to a person. So everything is basically done by the machine, and all the instructions are taken by the machine. So restorations are milled from prefabricated blocks of porcelain, and after the restoration is examined, approved, polished, it is inserted using the conventional bonding technique. So, of course, you have to do the placement yourself. The the CAD cam is not going to do your placement. So you have to call the patient and then you can fix the crown. So results with the in-office milling machine appear to be good as those of the lab milling machine. So they are very similar results. So it can be used in short. Okay, so you can see that this is a CAD cam setup. CAD cams consist of a monitor, a scanner, and a milling machine. Okay, so this is the CAD and this is the cam. Okay, fine, and this is the scanner. So once you take the scanner, you scan in the patient's mouth. You can see it on the computer, the computer aided, and then you can do then you can do a designing by the CAD, and then instructions can be given, everything done, everything modified, do the changes, and then it can send the signal to the CAM, that is the computer aided machine, milling machine, and the milling machine is going to do the job. You have to put a block of ceramic here, and then we'll discuss that further, and then the rest of the procedure can take place. Okay, so the intraoral scanner, the patient is sitting and the scanning is going on. This is what you can see on the monitor. You can do designing of the crown, see everything done, everything scanned and done. A ceramic block is placed in the milling machine and it's done. Okay, so coming to the office-based devices, that is the CERAC, which is first. So CERAC is basically share-side economic restoration of aesthetic ceramics. So it is basically a computer-aided design and manufacturing system for dentists. Okay, so these are just an example of the systems. Then coming to E4D dentist system. Now, this is again a comprehensive chair-side computer-aided design and manufacturing system produced basically for inlay only, full crowns, veneers. So again, another system. Okay, coming to CareDent iTero. So this is a scanner to digitally capture the structure of the teeth, gums, and later it can be processed. This is a digital scanner. Again, this is also the same system. So these are all office-based systems. So Lava, ShareSide, oral scanner. Okay, so this is also an oral scanner. Okay, coming to the materials which are used in the advancements of the FPD. So coming to ceramics. So for now, as for all restorative materials, the strength, clinical performance, and longevity continue to be the ideal requirements of a ceramic material. To date, those ceramic materials which appear to have the strength for use in posterior teeth as full and partial coverage restoration include the Ceram, the Procera, and Embrace. So these are famous companies which produce extreme strength and highly aesthetic ceramics. Okay, coming to the Expa Slay gingival tissue retraction paste. So impression making for FPD require the access of the prosthetic margins, so we need to see the margins properly, and we need to see that it is minimally traumatizing the tissues. So XPAS Lay is newly introduced unique paste system designed for gingival retraction to ensure separation of gingival margin and drying of the sulcus. So this unique system okay, sorry. This is a repetition. I'm sorry. The sulcus is left open and dry and ready for impression making. So you place the express slay paste in the gingival margin tissues. When it's ready to dry, you can actually take an impression. So it's basically made up of two materials. It's the kaolin and Al2Cl, which act as a hemostatic agent. Okay, kaolin is a clay-like material responsible for rigidity of the material. Okay, so Rest other improvements or advancements are improvements in alginates. So you can see that there are different types of alginate which have started coming for a long time now. So there are flavor which is added. There's spearmint, mango, mint. Rapid set are also there. The neocolloids. They are dust free also. There are base form catalyst plus base. Then alginate consisting microbial, sorry, which is chlorhex and quaternary, quaternary aluminum. So wherever indicated or required, we can also use these types of magnets. Okay, so now coming to the last portion of our presentation, which is the recent advances in the removable partial denture. So precision attachment was introduced, and what are these attachments? So these are basically connectors consisting of two or more components. Okay, so this is like the ball and socket type of component. We'll talk about this further. So one component is basically connected to the teeth or root or implant. The other is connected in the prosthesis. So these are precision attachments. So these are of two types, that is intracoronal and extracoronal. This is outside and this is on the surface. Okay, based on the geometrical configuration and design of the attachment, there are different attachments. So this is like a key and a keyway, and this is like a ball and socket. Okay, and this socket will fit on the clip on the ball. This will place like a key, and this is a bar and clip, so it'll be like a clipped on the bar attachment. Okay, so now coming to the indications for attachments. So there are many indication and contraindications for these attachments to be used. So first of them are movable joint in fixed movable bridge work. So if you have to design such a processes where one portion is fixed and other is mobile, so that also like a fixed bridge in the interiors and a rest of the distal extension is a CPD, and so there can be an attachment and it can be fixed. As a stress breaker in the free and saddles and bridges, so it can act as a stress breaker as well. Then retainers for aesthetically critical RPD, where class do not want to be visible. So in such cases also it can be designed where the patient does not want any class visibility, but of course it has to be indicated in such cases. And as connector for sectional dentures. So coming to the contraindication, so when there is a dexterity issues with the patients, so the patient will not be able to remove and place it back well. So coming to the poor hygiene, oral poor hygiene, if patient is not able to maintain it well, high caries index or rate, inadequate space to use, so like very narrow buckling beneath the teeth, and then weak abutment teeth structurally, and non-parallel abutments where the crown will need to be too bulky to allow the parallel path of insertion. So there, these attachments will not work. Okay, so coming to the advantage and disadvantage. So advantage definitely is aesthetic. So labial or buccal clasp arm can be eliminated completely along with the rest. So reduce stress on the abutment teeth compared to conventional clasp. All the stress is directed along the long axis of the tooth, right? Because if you have a attachment one end on the prosthesis and one end on the other movable portion of the prosthesis, it will all be dissipated out and it will not be on the tooth structure. Then avoidance of wear on abutment porcelain or enamel, reduce risk for dislodgement of crown from retentive unit. So yes, we have a three systems of retentive unit, like we have discussed: bar and clip, ball and socket, and that key and keyway. So it will enhance the retention of any prosthesis. So disadvantage is that tooth may have extensive cut to provide enough space to accommodate an intracoronal attachment. That is true. So there can be excess amount of cutting which is involved. Okay, a bulge in the crown is usually created for incorporation of intracoronal attachment. Yes, so the crown will look a little bit bulky because you're trying to fit in one component of the attachment. The attachment is subjected to wear as a result of friction between the metal parts. As wear occurs, the male portion fits more loosely, thus allowing excessive movement. So sometimes that looseness and friction can be created. Hence, this may lead to the injury to the abutment teeth and will reduce the retention over time. So these are certain disadvantages. So we can decide and uh, then only assess the case. Only if indicated, it can be done. In not all the cases, precision attachment or any type of attachment gives a successful result. So it has to be properly assessed and okay, so thank you so much for patient listening and hope you understood the topic. If any questions, please feel free to contact me and you can meet me in the Prosto Lab or Prosto Floor, or you can also search about these things on the in the recent journals, articles, and you can also learn new things about the same topic. Thank you.